Hello and welcome to Talking About Tumors with Ryan and Ryan. I'm Ryan Holstead.
And I'm Ryan Quinn.
And today we're going to move along with our lung cancer discussions and talk about systemic therapy in metastatic non-small cell lung cancer, specifically in tumors without driver mutations. So no negative for EGFR, ALK, ROS, etc.
Hope everybody had a nice weekend, and happy belated Father's Day to all the dads out there. This was Ryan's first Father's Day.
And it was wonderful. We'd like to thank everyone who's been listening along. We usually plug this in at the end of the discussion, but we'd certainly appreciate for those of you who found this as a useful resource to rate and review us on whatever podcast app you're using. This helps other people find it. Certainly we appreciate any word of mouth spreading about the podcast, and we know lots of you have continued to listen and really appreciate it, and hope to continue to make this a useful resource to those of you who've been following along.
On that note, let's just dive into the world of metastatic lung cancer without a driver mutation. So as we said, the majority of patients with non-small cell lung cancer actually present with metastatic disease. So this is definitely something that you'll see a lot. I know when I'm doing my inpatient consults, we get a lot of consults for new metastatic lung cancer. So it's always important to know staging and things to look out for.
And although the bulk of a lot of the new evidence and targeted therapies are specific to certain mutations that will show up on your NGS panel, and absolutely any patient who has a new diagnosis of metastatic non-small cell lung cancer should have some form of molecular studies performed. The vast majority of the patients you will see are going to be negative for these driver mutations. And it's good to be aware of both the principles of chemotherapy and the added value of immune therapy, so you can provide the best care to most of the patients you're going to encounter with this disease.
It's also important to make sure to get an MRI of the brain, even if the patient doesn't have symptoms, because it is relatively common in lung cancer.
Yeah, and we went into some details on the staging during our prior discussion. A couple things I just want to reiterate and drive home. Time to diagnosis is important. These are cancers that can have a significant impairment on someone's functional status and lead to heightened symptom burden in the course of weeks to months. And certainly timely diagnosis, identification can be the difference of being able to offer systemic therapy or to focus primarily on supportive care. These are cancers that may present with cancer-related emergencies. They can spread to the bone, causing cord compression, brain as Ryan mentioned, as well as causing SVC syndrome. So sometimes you may be dealing with the acute complications first. Other things to always think about are pleural effusions that might need to be drained, pericardial effusions. But at the same time, while focusing on dealing with the acute issue at hand, trying to get a timely biopsy.
So 2 things to look out for in the pathology report when you get a diagnosis are the histology and the PD-L1 status. Unlike other cancers where the exact histology doesn't impact treatment as much, such as breast cancer where invasive ductal and invasive lobular are still kind of treated similarly, in lung cancer, adenocarcinoma and squamous carcinomas are treated actually much differently. So it's important to know which type of histology you have before starting treatment.
We did get into the differences in the immunohistochemistry between these tumors. One thing we did not discuss last time are some differences in behavior. And one thing I think is worth mentioning about squamous cell carcinoma is that these tend to arise more in the tracheobronchial tree. So they may be more likely to be a central lesion, maybe more likely to obstruct your airways or actually invade through. And these are the types of lung cancers that you'll see the risk of pulmonary hemorrhage with.
Yeah, which becomes important when we talk about treatment and especially VEGF inhibitors such as bevacizumab.
One other thing to keep in mind is this concept of oligometastatic disease, which means a tumor with approximately 3 or 4 metastatic deposits. Similar to melanoma, similar to colon cancer, lung cancer is a disease that if you do have a solitary lesion elsewhere, you may attempt to treat the localized aggressively. However, this is generally uncommon. What you're more likely to see is in a patient who ends up responding to systemic therapy may have a solitary area of progression. And that's something that you might target with localized radiation such as SBRT and then continue on with your systemic therapy, which we'll get to in a moment. One last thing before we get into systemic therapy is the importance of palliative care in all metastatic diseases with poor prognosis such as non-small cell lung cancer. It's always valuable to include best supportive care, symptom management, pain management, nausea management. And interestingly, the first advanced disease to actually show improvements in overall survival with incorporation of palliative care to best supportive care was seen in lung cancer. And there's a paper published in 2010 in the New England Journal that randomized patients to having a palliative care consult from day 1 to just best supportive care in addition to systemic therapy alone. This was 100 151 patient study, randomized 1-to-1. They found that during the course of treatment, patients had better quality of life, less likely to have depression, less likely to be admitted to the hospital and have aggressive measures within the last 2 weeks of life. Impressively, an improved survival of 11.6 months versus 8.9 months. This has been also shown in some other advanced diseases subsequently, and certainly points to the value of utilizing all your allied care providers when it comes to cancer care.
Yeah, I feel like this also is a common thing that you get asked on rounds as well as on standardized tests. People love this, palliative care increasing not only quality of life, but actually length of life in this study.
For those of you who are having your first conversations with patients with life-limiting diseases, it's important to get familiar with how to present this to a patient. A lot of people come with preconceived understandings of palliative care, and finding a way to approach it is this is a way we're going to help you feel well while we continue to treat to the best of our ability the diseases. You'll find within each of your own styles a way to do that.
So getting into treatment, in metastatic disease, systemic therapy is going to be our go-to. And the exact chemotherapy that we use, as we said, depends on if you have adenocarcinoma or squamous carcinoma. However, you will hear the term platinum doublet, and that applies to both histologies.
The utilization of a platinum doublet emerged over 20 years or longer of research. And in the 1980s and 1990s, various chemotherapy regimens were attempted. Many trials were run. Ultimately, a meta-analysis published in the early 2000s found that 1-year survival seemed to be best using a cisplatin-related monotherapy, and that increased overall survival by about 10%. 15 to 25% at 1 year versus best supportive care alone. Using a cisplatin monotherapy increased median overall survival from about 6 months to 8 months. We moved into the doublet era, looking at different combinations of chemotherapy, and found that although it slightly increased toxicity, we were able to significantly improve survival, and this seemed to be best using a cisplatin backbone in addition to some other chemotherapy, whether or not that was gemcitabine, paclitaxel, etoposide, vinorelbine, or pemetrexed. The doublet seemed to improve overall response rate from 13 to 25%. 1 year overall survival was increased by 20% overall. The measurements in this meta-analysis found 30 to 35% in 1 year. And this follow-up meta-analysis that was published in 2004 had also looked at triplet regimens, so cisplatin plus 2 other chemos, and did not find improved survival using 3 instead of 2. And that led to doublet platinum agents being the standard of care for the next 20 years.
So anybody who's used cisplatin before knows that it can be very toxic, can cause a lot of nausea, vomiting, neuropathy, ototoxicity, requires a lot of fluid. So if you have anybody with heart failure, causes renal insufficiency, so it can't be used in people with underlying renal disease. So it is a very toxic drug and very difficult to give. We try to use this drug as much as we can in the localized setting, which we'll get to, because there have been studies that show that it is very effective. In the metastatic setting, and you're really not going for cure, most people will tend to use carboplatin rather than cisplatin.
A meta-analysis of the trials looking at carboplatin-based regimens versus cisplatin-based regimens, accounting for about 3,000 patients, found an overall survival to be somewhat similar. The hazard ratio was 1.07, which means that there's approximately 7% improvement in favor of cisplatin over carboplatin when we talk about overall survival. However, this was thought to be clinically insignificant next to the significant improvements in toxicity and tolerability.
And as we'll get to with immunotherapy coming into the picture, these studies have mainly been done with carboplatin and immunotherapy.
In general, these trials that had emerged used approximately 4 to 6 cycles of chemotherapy. This was often initially more focused during the cisplatin era because it's very difficult to give more than 6 cycles of cisplatin. But carboplatin has similar issues, and you run into further myelosuppression and difficulties using further cycles after 6 cycles. So in general, patients will be treated with 6 cycles. If you obtain a response, you then move into a phase of monitoring, with some caveats that we'll get to in the modern era.
So there was a pretty famous trial, the Scagliotti study, which was published in 2008 in the Journal of Clinical Oncology. And this was one of the first studies to show that histology actually matters in non-small cell lung cancer. The study was a phase 3 trial. It randomized about 1,700 patients to first line either cisplatin gemcitabine versus cisplatin pemetrexed. And the primary outcome was overall survival.
Pemetrexed was one of the first new chemotherapies that come out after a number of years. This is an anti-metabolite. The way I've heard it described before, is almost like a combination of 5-FU and methotrexate. So 5-FU, which blocks thymolate synthetase, and methotrexate, which blocks dihydrofolate reductase. Pemetrexed blocks both of these. It had showed some improvements in outcomes in patients with mesothelioma, and due to some preclinical data was moved into the non-small cell lung cancer space, leading to this trial at hand. Worth noting, some of the early mesothelioma trials were cut short because people had intolerable toxicity with severe rash, severe nausea and vomiting, and severe myelosuppression. People cleverly realized that this might have been a metabolite issue, and they found that incorporating folic acid daily and intramuscular B12 ended up leading to resolution of the severe toxicity and making it actually overall a fairly tolerable chemotherapy.
So in the total population, the overall survival was actually similar. Both groups had an average 10.3-month overall survival. However, when they looked at the pre-specified subgroup analysis, so again, this was specified and powered for this. This was not a kind of post hoc subgroup analysis. The overall survival for patients with adenocarcinoma was actually superior for cisplatin pemetrexed, 12.6 months versus 10.9 months. When they looked at patients with squamous cell carcinoma, they saw the opposite. So the overall survival was increased with cisplatin gemcitabine, 10.8 versus 9.4 months.
Although in general, the mantra is subgroup outcomes are hypothesis generating and not necessarily something we should drive practice by. The level of difference between the two histologies and the fact that this was pre-specified, so they were able to do an adjusted analysis of this, has led in general to the consensus that pemetrexed is effective, is at least as good as, if not better, than alternative secondary agents for adenocarcinoma. Does not appear to be an effective utilization in squamous cell carcinoma. To add further weight to this hypothesis is, from a cellular level standpoint, it is well known that squamous cell carcinomas are highly expressing of thymolate synthetase. So it makes sense that a drug that's blocking this enzyme will be less effective in a cell type that is highly expressing that enzyme. So I think given both the basic science understanding and the clinical outcomes during this trial has led to, in areas that have access to pemetrexed, preferring this for adenocarcinomas. Carboplatin findings have been extrapolated as well. This was a trial that didn't use cisplatin, but preceded the general consensus to use carboplatin over cisplatin for tolerability. Toxicities that were seen in the patients with pemetrexed, although were not the severe rash and nausea that were seen prior to the folic acid and B12 supplementation, patients did have some mild nausea. Rash could present, typically as a petechial rash. Elevation in liver function tests, myelosuppression, and AKI, acute kidney injury, which is relevant because when we're talking about immune therapy, both the drugs can cause acute kidney injury. Sometimes this can be a difficult diagnostic dilemma, which drug is causing it. And there's also the possibility of something called radiation recall. I don't think we've talked about radiation recall yet, but that's essentially when you have a chemotherapy that's a radiosensitizer, which pemetrexed is. It can sometimes cause recurrence of prior radiation toxicity. So this might be a rash on the skin, pneumonitis in the lung, colitis as well. Some other well-known radiation recall drugs include capecitabine, epirubicin, 5-FU, and taxanes. So sometimes you're pretty impressive as a rash that might be over a very specific field that would have been your prior radiation, and serve as very good board questions if you were to have a picture of a circular rash after starting one of these agents. So it's good to be aware of pemetrexed, capecitabine, epirubicin, 5-FU, and taxanes as the most common cause of radiation recall. So on the topic of how many cycles to give, one of the thoughts were, can we give pemetrexed for a longer period of time? Unlike taxanes and platinums, this does not appear to have cumulative toxicities, whether or not that's in the topic of myelosuppression or neurotoxicity. Paramount trial, which was published by Paz-Ares and colleagues in 2012, did look at continuation of pemetrexed. The patients received cisplatin and pemetrexed for 4 cycles. And in patients who were responding, so had evidence of disease response at 4 cycles, they were randomized 1-to-1 to continue what was called maintenance pemetrexed every 3 weeks or observation alone. The primary outcome for this study was progression-free survival. Secondary outcome was overall survival. And at the final analysis of overall survival, it was found that this overall survival was significantly improved in the maintenance group with a median overall survival of 14 months versus 11 months. Of note, something always worth keeping a look at when you're talking about patients randomized to observation alone. Did patients have a equal opportunity to get some form of therapy after further progression? And at least in this study, it did appear that there's a balanced post-discontinuation therapy. So both the pemetrexed group maintenance and the observation group, once they did progress, were just as likely to receive systemic therapy regardless of which arm they were in.
So we'll just mention briefly bevacizumab in addition to these chemotherapy regimens because it is a regimen that you'll see listed on NCCN as an option. However, I personally haven't really seen this used very much. So bevacizumab is actually contraindicated in squamous cell cancers because, as we said, that these have a higher risk of bleeding just given the location. And in prior studies, it was shown that there's actually a pretty high risk of pulmonary hemorrhage. So anybody with a squamous malignancy or evidence of hemoptysis would not be a candidate for bevacizumab, which, as we know, is a VEGF inhibitor. This was first studied in combination with carboplatin and paclitaxel with the addition of bevacizumab every 3 weeks. And there was a small but marginal overall survival benefit of 12.3 months versus 10.3 months. However, in a separate trial looking at bevacizumab added to gemcitabine cisplatin, there was actually no overall survival benefit. And the PFS was also very similar, 6.7 versus 6.1 months. So it's kind of unclear why the addition of bevacizumab, seemed to prolong overall survival in one study with one chemo backbone, and it had really no difference with a different chemo backbone. So it's kind of unclear if it has something to do with the chemo or the interaction. But I think because of these conflicting data, bevacizumab isn't really used, but it is still listed as an option, perhaps if somebody isn't a candidate for immunotherapy. I think in the era of immunotherapy, there's really not much role for bevacizumab.
Was not approved in Canada with any backbone. I think the questionable benefit cost was the limitation there. Should we move into the era of immune therapy?
So getting into the exciting topic of immunotherapy, although we've talked about it so much in all these podcasts, probably not that exciting anymore. Although something exciting I learned was that the KEYNOTE-001 study was actually pembrolizumab in non-small cell lung cancer. So the number 001 trial. So for metastatic lung cancer, virtually every patient, unless they have a contraindication, is a candidate for immunotherapy, regardless of the PD-L1 status. Although it is important to check PD-L1 because that will affect whether or not you give chemotherapy in addition to the immunotherapy.
In the case of lung cancer, the PD-L1 score we use is the TPS score. So remember, there's a CPS score and a TPS score. So in this case, it's the tumor proportional score, which there's many regimens that are now approved. After nivolumab had shown benefit in the second-line setting, the majority of the initial trials that came out that were positive were utilizing pembrolizumab. So we'll focus on the major pembrolizumab trials, but I think it's fair to say that in general you can substitute pembrolizumab for cemiplimab. There's also some evidence for atezolizumab in combination with bevacizumab. Look at those trials independently on your own as well as what might be accessible to your local region.
So we won't get into the details of the very early studies, such as the KEYNOTE-001 trial, but it was shown that patients with a higher level of PD-L1 expression tend to benefit more from immunotherapy. So then the thought was, can we substitute immunotherapy single agent for the platinum doublet chemotherapy that was being used at the time. And this was first looked at in the KEYNOTE-024 study, which randomized 305 patients with newly diagnosed metastatic non-small cell lung cancer to either pembrolizumab versus the platinum doublet chemotherapy. The primary endpoint of this was progression-free survival, and it did show that in patients with a PD-L1 greater than 50%, pembrolizumab did prolong the PFS, 10.3 months versus 6 months. There was also a higher overall response rate, 45% versus 28%, and a higher overall survival of 26 months versus 13 months.
This translated into a 5-year overall survival of 30% versus 15%. So significant improvement if you remember back to our 1-year survival of 25% using a platinum agent alone in the past.
One of the interesting things was this study looked at pembrolizumab for a total of 2 years. So many of these patients still had a benefit even after stopping the pembrolizumab. Still kind of up for debate in clinical practice today whether stopping at 2 years is enough or if you should continue on. I think you'll hear different things depending who you talk to, but in these studies, many of the studies that we're going to be talking about, there was a finite period, such as 2 years.
There does seem to be some residual benefit, although the quote-unquote tail on the curve is not as impressive as we see in melanoma And at the most recent updated analysis, there do still seem to be increasing numbers of deaths. It's also worth mentioning that in this trial, as well as the equivalent cemiplimab trial that also looked at PD-L1 greater than 50% using immune therapy alone, is primarily a non-squamous trial. So in the KEYNOTE-024 trial, this had 80% patients with non-squamous. And when they did look at subgroup analysis, it did not seem like the squamous cell lung cancers were as likely to benefit from immune therapy monotherapy. And certainly something to be mindful of if you're deciding to approach someone's cancer that way.
So because of this study, patients with the PD-L1 greater than 50% could be a candidate for pembrolizumab or another PD-L1 inhibitor monotherapy. One exception would be people who are very symptomatic. If you're trying to get a quicker response, these patients, you might want to consider chemotherapy plus immunotherapy, because as we know, sometimes the immunotherapy can take longer to have a response. So if you're worried that someone's very symptomatic and you need the response quickly before they're no longer a candidate for treatment, you may reach to the chemoimmunotherapy instead.
In patients with PD-L1 less than 50%, getting away with immune therapy alone is less likely to be beneficial. And multiple trials have been run looking at all comers, combining immune therapy. Primarily, we'll talk about pembrolizumab here, as it was one of the first to publish, in combination with a chemotherapy backbone. So there's parallel trials run in both non-squamous and squamous cell lung cancer. In the non-squamous trial, this was looking at a carboplatin pemetrexed doublet in addition to pembrolizumab versus carbo and pemetrexed. In both cases, the pemetrexed was continued for 2 years and the pembrolizumab was also continued for 2 years. In the case of the squamous cell trial, looking at all comers, this was using either paclitaxel or nab-paclitaxel in addition to carboplatin. And in this case, they were only given the chemotherapy backbone for 4 to 6 cycles. In both trials, very similar designs. They were stratified based upon what was called PD-L1 negative, so less than 1%, or greater than 1%. In the case of squamous cell carcinoma, they did find in the total population there was an improvement in overall survival of approximately 16 versus 13 months median overall survival. They did find that the benefit seemed to be among all 3 divisions, which was less than 1%, 1 to 49%, and greater than 1%. And at 5 years, they did find the overall survival to be significantly improved at 18% versus 9.7%. I should mention in the initial publication looking at the less than 1%, the squamous cell trial did quote 1 year overall survival of 64 versus 43%, which sounds very impressive. But when you look at the follow-up study, it seems like this cut point that they used was the widest time that the Kaplan-Meier curves are apart. So although there's 20% difference in overall survival at 1 year, everywhere else along the time frame, overall survival was much closer and probably in the less than 1%, very similar, especially as follow-up continued. So it's always good to take a look at the Kaplan-Meier curves yourself, because if you read an impressive 1 year difference in overall survival, this doesn't mean a whole lot if 3 months later there's no difference in overall survival. And it's sometimes can be a deceptive way of presenting data. Overall survival was even more impressively increased in the non-squamous study. And in this case, the median overall survival was increased from 10.7 months to 22 months using the pembrolizumab and chemotherapy combination, with a 5-year overall survival of about 20 versus 16%. Once again, benefit seemed to extend just whether this was less than 1 to 49, or greater than 50%. However, the benefit did seem to be greatest in the higher PD-L1 cutoffs.
So due to the study, again, all patients, regardless of PD-L1 status, will get immunotherapy added to their chemotherapy backbone. So with non-squamous cancers, you would see carboplatin, pemetrexed, and pembrolizumab. Sometimes we call this carbo-pem-pem. And in squamous cancers, typically either carboplatin, either paclitaxel or nab-paclitaxel plus pembrolizumab.
So in addition to studies similar to above using cemiplimab with or without chemotherapy, depending on PD-L1 cutoff, as well as a study using atezolizumab and bevacizumab in chemotherapy in all comers, there has been also studies done using the combination of nivolumab and ipilimumab. This is using the flipped dose, so nivolumab of 3 milligrams per kilogram and ipi of 1 milligram per kilogram. Remembering the lower the ipi dose, the less likely to have toxicity. There was 2 trials. One trial used using immune therapy alone, the Checkmate 227 trial, and another trial using the combination of Nivo, Ipi, as well as a chemotherapy background, or also known as the Checkmate 9LA trial. These are both positive trials as well, with the trial using Nivo and Ipi alone showing improvements in all comers with a median overall survival of 17 versus 14 months. And this benefit did seem to extend across all PD-1 subgroups. Once again, the benefit seeming to be the highest in PD-L1 greater than 50%. And in the Checkmate 9LA trial, using the combination of chemotherapy, ipilimumab, and nivolumab. And worth mentioning, in the case of the Checkmate 9LA trial, Nivo and Ipi and chemo were given for a total of 2 cycles, and then was continued with nivolumab and ipilimumab ongoing for up to 2 years. In this case, the median overall survival was 15.6 months versus 11 months. Is Nivo and Ipi with chemotherapy or without chemotherapy better than pembrolizumab with chemotherapy or without chemotherapy or any of the other agents? I don't know.
Yeah, I think it's hard to know, who should get this as opposed to who should get kind of the more classic, chemoimmunotherapy with pembro. And I doubt there'll ever be head-to-head trials, so I guess it'll be up to us to kind of interpret the data. I personally haven't seen this used very much at my center. I don't really have a good reason for that, but I'm not sure if maybe the fear of the toxicity with the dual immunotherapy is driving that, or if people are just more comfortable with what they've been doing with the carbo-pem-pem or carbotaxol-pem.
I've seen a few patients on the Checkmate 9LA trial using the Nivo and Ipi and chemo. I've not seen incredibly higher toxicity with this, but I haven't seen a good reason to choose this over the other.
Hopefully there'll be more studies and more insights on this.
I think it's worth mentioning this is a really exciting time, and when we look back, we're really talking about trials that have come out since 2016 or later, which in terms of developing new regimens is a very new period, and these are likely all to change rapidly, and probably by the time we update this episode we'll have a whole new framework on how to utilize the best immune therapy based upon pathologic biomarkers.
One of the most frustrating things about trying to learn oncology, by the time you have it memorized, it's probably changed.
Thankfully, platinum doublets don't look to be going anywhere anytime soon.
So getting into second line, if somebody progresses on first line, either chemotherapy or immunotherapy, what do we go to next? One of the most studied regimens has been docetaxel, which is one of the few that actually has randomized controlled trials looking at this. So that's a common go-to second-line therapy. And this is really regardless of if the patient had gotten paclitaxel in the first-line setting. If you didn't use immunotherapy up front, you can always reach to immunotherapy.
If they got immune therapy alone up front, you could consider using a platinum doublet in the second line.
And then there's a few other options such as gemcitabine, vinorelbine. The combination of ramucirumab, which is a VEGF inhibitor, and docetaxel has also been studied. So a few options. But honestly, you're kind of in not a great spot when you're on second-line chemotherapy or second-line treatment for, metastatic non-small cell lung cancer.
We mentioned this at the top of today's discussion, but if you are having someone and they're on that 2-year immune therapy maintenance regimen, whether that's pembrolizumab alone, cemiplimab alone, Nivo-Ipi, or pembro and pemetrexed, and you have just a solitary lesion progress, do consider treating this locally with something like SBRT radiation, because solitary progression may not mean necessarily treatment failure. Worth mentioning, Ryan mentioned the docetaxel and ramucirumab trial. Compared to best supportive care alone, docetaxel did show to improve median overall survival by 2 months, which is small when we're talking about a survival of less than 11 months, but for some people that is worth the continuing therapy. Ramucirumab, however, improved. So combining docetaxel and ramucirumab versus docetaxel alone improved overall survival by about 1 month. Pretty small, doesn't add a whole lot of toxicity, so certainly something to consider, but it's also a very costly agent, and depending on access, it's good to be mindful of whether or not this is truly something that's going to benefit your patient. Although the overall survival a month was statistically significant, I think there's a lot of questions on whether or not that's clinically significant. Beyond reaching to another line of therapy, it's also good to be conscious of the timing of progression. So if someone's progressing and they're in the midst of getting a platinum agent or in the midst of receiving immune therapy and have widespread progression, then you really need to reach for a second line agent. On the other hand, if you were to complete your 4 to 6 cycles and on monitoring, or if you were to complete your immune therapy for 2 years and then in monitoring, and 6 months to a year later this progression starts, you may want to re-challenge with what had been effective up to that point. And in general, with platinum agents, if progression happens 6 months after completing the therapy, it's worth considering re-challenging with a platinum because it may still be platinum sensitive.
Okay, so to wrap this up, some bottom lines. So as we said, the majority of patients with newly diagnosed non-small cell lung cancer will present with metastatic disease, and it's always important to check for driver mutations.
For those without driver mutations, standard of care is going to be chemotherapy with immune therapy, or if you're dealing with a PD-L1 greater than 50%, maybe immune therapy alone. Your chemotherapy backbone, based upon the meta-analyses that came out in the 1980s, 1990s, and early 2000s, have shown that platinum agent is the best chemotherapy around, and in combining this with a secondary agent is better, and combining to a third chemotherapy does not seem to add a benefit over two therapies. So we deal with the platinum doublet being our standard chemotherapy backbone, given for 4 to 6 cycles.
Histology matters. So for patients with non-squamous cancers, you want to reach to pemetrexed for your platinum doublet. And for patients with squamous cancers, you would reach to, most commonly, the paclitaxel or nab-paclitaxel.
Modern chemotherapy doublets are often going to use carboplatin. The toxicity of this seems to be better than cisplatin. The difference in efficacy seems to be a minimal clinical difference in the metastatic setting. This is different than when we talk about the curative setting and localized disease. At this time, the immune therapy regimens have mostly been studied, being given for a total of 2 years. The optimal duration is still something that's yet to be confirmed.
And for second line, you can reach to either docetaxel single agent, ramucirumab docetaxel. If they initially had a good response with chemoimmunotherapy, you can re-challenge or use something like vinorelbine or gemcitabine.
Also be aware of your next generation molecular profiling. Just because a driver mutation for first line was not available, there are some driver mutations that have shown second line efficacy, and we'll get to those in more detail during our next discussion.
Thanks for listening. Hopefully there's not too much background noise. It's a beautiful night in New York, and I think everybody and their dogs are outside. Hopefully we can filter out the barking and the honking horns.
Bye for now.
Bye. For more information, follow us on Twitter at Talking Tumors, or feel free to email us at talkingabouttumors@gmail.com.
Please rate and review the podcast. We really appreciate it.
And special shout out to our friend John Kim for all of his musical talents.
And he is the composer of the music that you're hearing right now. Talking About Tumors is not medical advice.
For medical advice, please contact your own healthcare provider.
Opinions stated on this podcast are by the Ryan who said it and no one else. We have no financial disclosures, and this is done purely on our own time to the sake of our enjoyment of the field of medical oncology. Thank you for listening, and see you next time.